The fusions are structural changes in the genome, so they're chromosomes that are not normally paired, being abnormally paired and resulting in driving cancer. NRG1 fusion-positive tumors are typically aggressive in behavior. In patients with non-small cell lung cancer, they're often mucinous adenocarcinoma tumors. They're also found in patients with pancreatic adenocarcinoma or cholangiocarcinoma, in addition to several other histologies. NRG1 positive tumors are difficult to shrink with treatment, meaning the response rate is typically low, and unfortunately, patients with NRG1 fusion positive tumors typically have short overall survival. In the presence of an NRG1 fusion, the HER2-HER3 dimerization complex results in constitutive activation of cell growth and cancer development. So NRG1 drives cancer through the HER2 and HER3 interaction. Knowing what tumor mutations are driving a cancer can make a dramatic difference in the patient's outcome by allowing us to match targeted therapies to the driver mutations. In fact, studies have shown that when we know the genomic profile of a patient's tumor, patients may do better. When a patient has an actionable mutation, that means that there's a targeted therapy either directed at that mutation or that we should alter our treatment based on the specific mutation presence or absence. RNA-based NGS helps solve the difficulty in identifying pathogenic gene fusions that DNA-based NGS faces by removing the excess genomic material or introns that DNA NGS attempts to sequence. RNA-based NGS identifies gene fusions at a higher rate by looking at a more pure product. Only using circulating tumor DNA or liquid biopsy technology to identify genomic alterations in a tumor may result in missing targetable mutations, particularly actionable fusions. Studies suggest in up to 20% of patients, liquid biopsy alone would miss. While circulating tumor DNA analyses or liquid biopsies are easy to complete in the clinic, tissue-based NGS is still the gold standard to identify actionable mutations. Its sensitivity is beyond what ctDNA or liquid biopsy will ever be able to reach. I've found that it works best if there's a reflex process to identify actionable mutations rather than relying on individual physicians and systems to remember, to order, and complete single tests. The primary collaborators in interpreting particularly complex NGS results are our pathologists and colleagues in medical oncology who may have experience interpreting these complex results and determining therapeutic actions based on them.